things that has, happened along the way. And I want to preface this by saying, let's not use names. Let's not, call out TPAs or health plans, or, let's not get to that specific about things that have happened in the industry and in general terms, and how we do better going forward. If you have any questions or comments, please place them in the chat, and we'll monitor from there depending on how much time we have left over at the end. But I am very excited to have with us today. We've got a really strong panel, and we've got Allison Cohen out of San Antonio, who has she is an advisor, a health benefits advisor, one of the best, one of the most experienced at putting solutions in place and cost containment. We have Courtney Davis, who is with Skyward, which is a stop loss solution that is very involved in our kind of ecosystem, and I think has a lot of experience putting solutions, underwriting solutions. And then Dale Sagan, who I met at UPowered, and volunteered if I ever wanted more information on stop loss to be my resource, and so he's here today. And we've got Juliet Breeze, who is supporter of this chapter, and glad to have her on board as well today. So I had some specific questions I wanted to start out with. And what I'd like to do is just kind of hear from each of you on, and I'm going to start with Courtney and Dale, and then we'll have Allison kind of follow that up. They're both from the industry. We'll have Allison as an advisor follow that up and talk about where it impacts employers, where it impacts advisors, and where it impacts the solutions, from her perspective as an advisor, because I think that's super important as well. So let's start with the education piece, because I will admit to not really understanding until about a year ago the difference between individual and aggregate stop loss, and it's become a very important thing in my world this year, and had significant impact on revenue for my company. And so really want to hear specifics about how these two things differ and what their definitions are. So Dale, you're over to the left there for me. Would you start this?
Absolutely. Thank you, Dr. Dickerson. I would say that I want to start off with, when an employer is in the stop loss market, they have a self-funded health plan. So you are essentially saying to all of your employees via ERISA that we are responsible for the financial risks of the claims that happen under this plan. A lot of employers can't bear that risk by themselves, so they have to go to the stop loss market to make sure that they have their downside maxes capped and feel comfortable with that self-funded plan. Let's start off with the individual risks. It's often called specific stop loss. When there's an individual who has a very catastrophic event or a chronic condition where every single year they have a high cost of their health care needs, you purchase specific stop loss for that employer to say, this is the maximum exposure that I want per claimant, sometimes per family. Can be $30,000, $40,000, all the way up to $1 million. You just find a limit that you are comfortable with as an employer. And then aggregate stop loss is the weight of all the claims under that individual limit. So you could potentially have hundreds of individuals use a little bit more health care than you were expecting this year. The employer now has a runaway cost, and it may not be because of the high cost claimants. It could just be individuals just received, a $20,000 drug that just comes on the market for weight loss. You end up in a position where that health plan's costs are just too much for them to carry. Aggregate stop loss puts a cap on the most that you will pay. And typically it's about 125% of the expected cost of that plan. So there's a little bit of margin in there before the stop loss actually will reimburse the employer. But you can actually buy that down sometimes to 110% to really decrease the maximum exposure for that health plan. Courtney, do you want to add anything to that?
That was a great description, Dale. Thank you. I don't have a lot to add. I would point out for those of us on this call where it looks like most people are coming from different sides of the business. This is the part of stop loss that I don't know who created it or how we got here, but there's like acronyms and words that all mean the same thing around individual and aggregate. There's those two words and what they mean. There's ISL, ASL, specific stop loss, aggregate. Don't worry about getting tripped up as you think about the two. Dale did a great job of describing their definitions and sort of their purchasing effects. The only thing I would add is how they work together. And so when you think about this conversation that we're about to walk through in terms of building an ecosystem of partners and solutions, and how each of those impact both the spec, the individual, or the aggregate stop loss. As you look at your plan, only your claims up to the specific deductible that you purchase for all of the members accumulates towards the aggregate. And so I sort of highlight that as we go, so that you think about it as we go through some of these next points, because as you come down market and you're looking at, say a specific deductible or an individual deductible of, say anything under $100,000 or $75,000, if you happen to have a year where you have 4 large claims, your impact to your aggregate is realized much more quickly than a larger deductible, larger account that's much more experience underwritten. That's all I would add.
Okay, Allison?
I think the 2 most important things to remember are the individual or specific deductible is the most that you will pay for a covered expense for any one individual. And for some perspective, if you're a 50 life employer, your spec might be $35,000 or $40,000, and you're not paying that for every single employer that you have. Your aggregate is what you're going to pay for all of your people. And the math doesn't add up. You can't add all the $40,000 up and get to the right number, because not everybody's going to hit $40,000. One would hope not. And then as you get a little bigger, maybe you get to 100 or 125 employees, you're going to be at 60, 70, 75. If you're at 300, you should be at 100 or 125 until you get a little bit larger, and then you really should start ticking that number up. It will save you a significant premium dollars.
And Allison, I'm going to toss this in because I think this is one of the things that's happened in the market. Would you talk about the difference between, what level funding is, and as compared to the traditional self-funded claim, and why ag stop loss is so important in that setting?
Okay, so there's a couple of things to unpack in that question. Right. So let's talk about an ag only product first, because that applies to the very small employers. So if you're under 10 or 25 lives, you have a level funded plan, you probably have an ag only plan. You should have something called monthly accommodation. I'll explain what that is in just a second. And in a level funded plan, it's still self-funded, but you are paying your maximum liability every month. And at the end of the year, if you have any dollars left in your claim bucket, you retain them. And depending on what kind of policy you have is how you will retain them. Okay? If you're a little bit larger, and say you're 25 or 50 or 75 employees, sometimes it is harder for that size organization to make the leap from fully insured to self-funded. So you end up with something level funded. Level funded is just the payment arrangement. You're still self-funded. Level funding just means you're paying your maximum liability on a monthly basis, and you retain anything left over in your claims bucket. It's a really easy solution. it's much easier for the accounting people. Maybe that's a better way to say it. One of the big things I see when moving people from fully insured to a pay-as-you-go environment is they all think it's great for the first 3 months, and then the claims start to hit and the accounting people freak out because it's like, oh my God, I have to write a check for $10,000. Well, yeah, but you're way lower than you were before, and you didn't write a check for 10,000 up to now. Doesn't matter. It takes them a little while to get used to that. So sometimes level funding can be a great bridge. And sometimes we have clients that stay on that. That works for them, and that's fine. Again, you want to have something called monthly accommodation, and that means you take your annual ag factor, how much you are responsible in total, and apply that to a monthly maximum. So if somebody has a heart attack, you don't have to pay out $100,000 in 1 month. So I know that's a lot. I'll be happy to answer any questions if anybody has them.
Okay. And I would say that, people ask me what the trends are that I'm seeing, in kind of our healthcare ecosystem. And I would say there have been 2 trends over the last 2 years. One is navigation. It's become quite clear, and we know this from other kind of consumer-based healthcare products. Consumerism is hard to do in healthcare. It's complex. We don't have a very health literate society. And also, more importantly, when people are under healthcare stress, they just want help. And that's largely what healthcare providers do. Part of it is the science, but a lot of it is just the compassion and the help. And so navigation has proven to be key. The most successful products we see in the market are ones using navigation. Number 2 is actually creating health plans out of the solutions that exist, trying to find the best solutions in the market and pull them together so they're more cohesive for employers. And that is what we have seen as a trend, is that there are more and more of these level funding plans emerging for smaller employers. So adapting the self-funded kind of model for smaller employers. And I think that's one of the places where, we've really started seeing the disruption, because it's really easy for a big employer to bolt on solutions outside of their traditional BUCA, major health plan. What happens when we start getting written into health plans is problematic, and where we kind of hit the chaos in 2023. So let's go back to our stop loss friends. What are the challenges in underwriting stop loss for direct pay health plan solutions?
I'll jump first. Courtney, clean it up, please. My thought process is that stop loss is for unknown costs. It's the unknown risk that you are ultimately buying stop loss for. And it's the claims that could materialize. It's the utilization could increase. There's many different levers that could cause a health plan's claims cost to increase. When you start to bring in solutions, direct pay health plan solutions like you're referencing, it can be DPC solutions, it can be navigation, it could be your favorite data analytics platform. When you start to plug those in and then you ask the underwriter to pay for those in the premium, it's really difficult for an underwriter to say, well, that's not a claim. That's an admin cost, and that should be the cost based on your third-party administrator. They should be taking that on. So if you are expecting that the stop loss carrier is going to be paying those things, you need to make sure that it's covered in the stop loss contract appropriately, and honestly have a conversation directly with the underwriter and say, these are the things I'm really expecting you to pay for. Give me a cap, give me something, if anything, to make sure that I know that if claims were to completely go out of control, I'm going to receive some of that administrative cost back as well. That's something that I would question. But just challenges in general, I would say that a lot of those solutions, the underwriter doesn't have a crystal ball. They really don't have the ability to say, I know exactly what's going to happen next year. So the underwriter is often conservative in what that could be. There's expense loads that are added to the premium. And ultimately you get to a place where sometimes it just doesn't make sense to insure some of those costs. That's why you should be paying it self-funded on your admin fee and leave it outside of stop loss, in my opinion. But Courtney, please clean it up.
Nope, all good points. So I think it goes back to what we were talking about before, the individual and the aggregate coverage. So to Dale's point, you're asking an underwriter to kind of take a leap of faith on a solution that may or may not bear savings. But when you think about that, when people think about stop loss, they think about price. And so you're asking for premium reductions, but remember the premium, the key premium driver to stop loss is the individual or the specific side. And so as you think through these solutions, kind of, in what you're asking a stop loss underwriter to think about, you can ask yourself the question, do you anticipate this solution reducing large claims? And again, that could mean anything, like Dale said, from 20, 30, 40,000 all the way up to $1 million. The challenge in all of it in today's world is just the speed to market with which new entrants are coming on. I get calls every week. There's something new, somebody new. So how do we as an industry keep up with that? And is there a way to sort of, as an industry, stop loss industry, I don't want to say normalize, because all of us, believe we have a little bit of secret sauce around how we underwrite for these things, but how do we keep up with it? What is a standardized data set that we would like to see as an industry in order to be able to evaluate a lot of these point solutions? So I would put that out there for the group to sort of take back through FMMA, and maybe that's a workshop or a committee that I hope I didn't just nominate myself for. But those are the challenges, just the sheer number of solutions, what to do with them, how to draw differentiation within a group. So direct primary care, for example, I know we have some folks on from that world, all different kinds of models out there, all, have merit and value, but within a stop loss price, but also decrement to an aggregate calculation. How do we value for those different models that are constantly changing? And that's really, I think, the biggest challenge at the moment, and I think should continue through, at least through the next 12-month cycle.
Okay. Allison?
I think that data is the biggest hurdle right now. We're still not necessarily always getting great data. And let me give you 2 examples. In my experience, and Dale and Courtney can correct me if I'm wrong, a stop loss carrier will typically pay the fee associated with an RBP point solution. Not if you've got it on a per employee per month cost, not that. But if we've got a one-off claim and there is let's say we're using vendor A and they charge 10% and their fee is $2,000, often that will be covered by the stop loss carrier. A PEPM will typically not be covered by a stop loss carrier. And something like direct primary care should typically either be paid directly to the primary care firm, if it's an individual doctor or a practice or whatever arrangement it is, or it should be handled on the admin portion of your invoice. That's not a stop loss cost. Where you want to see stop loss go with that is you want ag decrements, but you can't get ag decrements until you have good data. And only now are we starting to see solutions come out of the DPC world where you can get good data, right? So you're not seeing a whole lot of decrements yet. And I know that can be frustrating for employers, but it's coming.
Fantastic. And we have a question from Jim Jesco about timing. What is realistic timing when we get to the level funded world and there's an ag stop loss accommodation? I know that there are a couple of time frames there, and this is where we got in trouble with solutions that are, their cost, like green imaging, their cost containment is based on, super fast payment to our providers and our radiologists. That's how we're able to achieve what we do, that and getting them out of the hospital systems. But, that prompt payment and then getting paid 6-8 months down the line, is problematic, especially with interest rates where they are. And so, what would, Dale, let's go back to you. What would a typical time frame, what would a realistic time frame be?
I would, quick little plug for QBE, I would say. So QBE, we do all of our aggregate reviews, our audits of aggregate claims in-house. So we could typically turn those out relatively fast. We're not outsourcing it to a third party to review where you have to give them all of the data and then they eventually come back with their thoughts on the claim. So because we're doing that in-house, it can take, a week, sometimes, 2, where it's, this is a claim that we expect, we have the data in, great, let's pay that claim, make sure that our client is happy. I would say you need to work with your carriers and make sure that you have a good idea of their ability to move through a claim quickly.
Yeah, because I know that, it's not just the stop loss carrier, it's also the TPA's processing time. Courtney, your thoughts on that?
You kind of just started to touch on it. Yeah. So, I think most of the stop loss industry, would give you, if you ask them the question, a turnaround time for a claim reimbursement in the stop loss world of 3 to 10 days, you're going to get an answer somewhere in there, which should be satisfactory. But ensuring that the TPA is really, we'll talk about this later, but fully integrated with all of these solutions so that when those claims are coming through and it's being submitted for reimbursement, it's complete and clean. And there's a million definitions of clean in today's world, but it's complete. So green imaging, for example, we see claims come in and then it's like somebody at the very 11th hour, like, oh wait, we forgot the green imaging claims. And so we're trying to, as a stop loss carrier, piecemeal those things together. So being able to really truly integrate at the TPA level in order to get the stop loss carrier what they need to do the turnaround time that everyone expects from market is critical in that.
Allison?
I would say that there are timelines that both TPAs and stop loss carriers need to follow, but you also have to live in reality, and often there is something that comes late, there's something that gets missed. There are some really excellent TPAs out there, and it happens even to them. So I would say that 30 to 60 days is a realistic time frame, and I think that's okay. Would today or tomorrow be better? Of course, but I think 30 to 60 days is a realistic time frame. And it also, particularly with the level funded plans, there are real financial constraints there. And you need to know what's going on in the stop loss world to make sure that they will reimburse quickly, because sometimes they're waiting for premium to come in for a particular program. And that is not necessarily in the world of either Dave or Courtney, but some of the level funded programs, they're not taking enough money in to fund the real large claims really fast. And nobody really talks about that, but it is a reality. And the other thing, and I'm going to call out a TPA, not by name now, is there is a TPA that has been processing claims and showing them as paid, but they're not actually releasing the funds. They have check numbers and they're not releasing the funds. And you can call and they say, oh yes, here it's paid, blah, blah, but it hasn't been released. And I suspect that that's what happens to you sometimes, Dr. D. And it's a real problem for a point solution vendor. If it's one time, okay, but it's not one time. It's a repeat offender type of situation. And that is a really big problem for a point solution. And it can be a really big problem for an employer.
That's a really good point, because that is, you give two things. Number one, 30 to 60 days probably for a point solution is okay. If you're filing claims electronically, you're going to get paid maybe a little faster than that. But if you're sending invoices, that's a typical time frame. The point that you make, however, about it hasn't been funded adequately, or the employer hasn't met their deductible yet, so there's not the adequate funding, is one of the things we heard was going on this last year. And so I think that's a really important one. One of the things that I was made aware by a panelist at UPowered was that they can release, even if they're auditing, if there are solutions in place that they've provided decrements for, they can actually release funds in advance of finishing that audit. Courtney and Dale, do you all have experience with that?
Wow, I do not.
I'll say so. Simultaneous stop loss reimbursements. We have an ASO expedited reimbursement product as well, where it's just limited filing is needed. We're going to ask for more data at a later time to be able to kick a check out for situations where there's just not enough information to pay a claim, but we know it's coming. That's an area where some stop loss carriers have the ability to at least push some money out the door with just limited information to make sure that a claim can actually be paid.
Allison, any experience with that?
No, actually.
Okay. Well, it's one of the things we need to think about as an industry, if that's something that could potentially be done to, make things move more smoothly in the ecosystem. Okay, so, kind of moving along, I'll tell you, Juliet Breeze, their data is amazing, as we're clients, and we get to see, what we've paid for next level services and what that equivalent is in the real world, and how many encounters our members have had. It's really awesome. Some of us do have data, and so how do we package that best for underwriting? What can we put out there? What kind of package can we create as a best practice that will, when we have a new potential client, we pass that to them and say, here, give this to your underwriters. How can we help? Dale, you want to start?
Sure. I'd love it. And Allison, I echo what you said. Data is the most important piece of this entire equation. Data is extremely valuable. I know some individuals that have their data sets under lock and key. They almost refuse to give it to an underwriter because they have their favorite underwriter and they may be taking risk on the stop loss from that perspective. So data is really, really valuable for me. I'll share with you that a lot of individuals don't spend the necessary time to consolidate it into a readable fashion. They just come up with a number on a PowerPoint and it's a bar chart. It says, here's our PEPY, go. Well, I need to know more than that. Our actuaries are going to ask, what's behind the scenes of that number? And if you don't open the door and give them that needed data, the actuaries at the stop loss carrier are not going to give you the needed credits to get to a competitive solution. Now, what I've asked for some individuals is, can you just look at your book of business? Who is using your solution? Your stack of solutions is a common term. And I want you to put that onto a high cost claimant report and a monthly aggregate report to be able to show me what this would look like as one large employer. And let me bring that to the underwriters. Let me bring that data set, because it's not, the usual flashy things that you see from some of these data analytics firms, but it does give our underwriters the ability to say, hey, this is good risk in total. You're telling me that this solution, you're going to go after a 50 life group using this solution? Yeah, I want to go after that business now. So I try to coach it up on the front end as much as I can.
That's great. We actually have a client that has 10,000 members, which makes it really easy to do a case study. That's good for my math anyway. Courtney, what are your thoughts there?
Yeah, I think putting it together in a package allows an underwriter to really look beyond each solution standing on its own, which, has its own merits and its own underwriting decrements, in the end. But when you start thinking away from, spreadsheet decrement and what that number is, and think about things more conceptually, as you put your packages together, as it relates to stop loss, I think about things like, okay, a nurse navigator is cool, but if it's not working together with the PBM, with the other point solutions that are in place, it's just kind of a nice phone number to have. And so how do you, again, think about embedding and integrating those solutions? And when you go up to the larger claims, the things that you see in the stop loss world, so cancer being, the number one, right? How do those point solutions integrate to bring the cost of an episode of that care down? So not going to be the end all, not going to keep someone from having a high cost event, but could at least chip away at some of the cost to that. And so how do you put your data together as a package to show a stop loss underwriter in that cancer example? If a cancer on average, if an underwriter looks into their crystal ball AMS system and sees the cancer that they're looking at is say $300,000, your package, all things firing on the right cylinders, would result in it being $260,000. Well, that's a conversation that everybody would like to have. The underwriter would like to understand and be able to provide a true value credit to the package or the stack or the program that's being offered.
That's a really good point, and something we need to think about, because imaging does become a big piece of that.
Mm-hmm.
Allison, your thoughts?
So I want to just explain what two things are. So a monthly ag report or a monthly aggregate report is how much was paid in claims. So you can track that through the course of the plan year. And a 50-50 report itemizes anybody who is over 50% of your individual stop loss deductible. So if you have a $50,000 individual stop loss deductible, anybody who spent more than $25,000 of claims during the course of the year would be on that report. From the employer side, if you're presenting this to an underwriter, you will have a much better result if you have diagnostic information. Okay, it was a stage 1 breast cancer, not a stage 4 breast cancer. It was a stage 1 multiple myeloma, not a stage 4 multiple myeloma. Not sure it's as important with multiple myeloma. And what point solution you have and their success in getting a better package. So you need all of that. You need somebody who can tell that story for you, that yes, you need the data, but you need the story too. Otherwise you're going to get no, and you don't necessarily have to get no.
Got it. Okay, well, let's flip this on its head. When we are evaluating a new health plan, somebody comes in and says, I want to put green imaging, next level, whoever it is, probably not as much next level because we should have that as an upfront cost, but something that could be written into the plan. What questions do we need to ask about how the stop loss coverage is being managed? What are the questions we need to ask to make sure that things are going to be okay and not like 2023? Dale?
Just off the cuff thoughts here. I would say don't be afraid to ask the risk partner, the stop loss carrier, the MGU, to ask questions about themselves. Are you rated? What is your authorization that you have to pay claims? What is your authorization to underwrite? Do you have more authority than maybe another one that could potentially make a smoother solution, a more stable solution if the stop loss didn't have softness that you could push into? You want to make sure that your stop loss partner is giving you a hard line on that downside risk. And I know there's some individuals out there that really just try to sell on price and just it wins on the spreadsheet and it is what it is. But when I see unadmitted carriers, unrated carriers, I see individuals that are putting a little bit more risk on their clients just because it's a lower price point on the spreadsheet. You need to kind of take a step back, and I know we're not saying names, but ultimately realize that there are horror stories out there and people are ultimately put at risk. And it's not just you, Dr. Dickerson, it's Allison, it's the advisors, it's the employees, it's the employer. Everybody's at risk if you accidentally place it with a carrier that's struggling to pay their payroll. So I would say, from my perspective, make sure you feel very comfortable with your risk partner when you start to build out these solutions. And don't be afraid to ask, what's your authority level on paying claims and underwriting?
Fantastic, Dale. Those are really good points. Courtney?
Yeah, I would say in addition to that, just making sure that, all parties and all parties that are contractually obligated to the plan are sort of in lockstep, not just with, verbal understanding, but, is the stop loss coverage truly providing coverage for, the plan itself? Anything that's in the administrative agreement, and any of these point solutions that are oftentimes left out of those documents. And so if they are you on the same side of the table with a stop loss partner, that values the effort of, taking dollars out of the system, and they're going to support that on the claim side? If one of those documents should be silent. So I'd say, working with whoever that is, whether that's counsel, there's a number of agencies out there, just to kind of get those documents lined up to where if you are with a stop loss carrier that's unproven, or that, it's new for them, you don't end up finding out, at claim time, what they purchased.
Allison, I'm going to word this a little differently for you, because, one of the things that happens is that our agreement with sometimes the employer, so if a TPA or health plan, that, if there are certain areas that where an employer is not bound to pay, we actually contract directly with the employer, so that the employer is, not just by ERISA law bound to pay us, but is bound to pay us, and then we get our payment terms in place. When those documents differ, my agreement differs from the plan design and differs from the underwriting, where can an advisor get in trouble there? Where does that risk go?
That sounds a little bit like an E&O claim to me. I think it's very important that the advisor team make sure that the administrative services agreement covers everything that the employer wants it to cover and excludes what they want it to exclude, and that the stop loss carrier has a copy of that document, certainly in draft form up front, and then when the final copy is available, as soon as it is possibly available, and that there is an agreement with the TPA on how it is that you are going to be paid as the point solution. As much as your agreement is with the employer, if this is going to work properly, the TPA has to administer. And if that is, you are a known provider to them on a direct contract-like basis, you send an invoice, we did this thing, okay, here we're paying you. If it is submit an electronic claim, whatever it is, that is agreed to upfront. It's not that hard to do. Sometimes it's fiddly for all the people to get in agreement, and just not even get in agreement, but just get the documents signed. And that is the most important part.
Yeah, and I think, I think all of us are learning along the way and figuring out ways to make it better and work, grease the wheel, but it certainly, there have been some drop balls along the way. One of the things, again, and I want to go back to this because I think it's important that everybody think about this, is, let's go through again what should be underwritten and what should not be underwritten, because there are a lot of point solutions, it seems to me, that look like healthcare that are not really underwritable. And so, Dale, would you start with that? I mean, as far as chronic care, what are some things that go to admin fees, and what are some things that should be should be underwritten?
Yeah, I would say any cost that's just an ongoing cost, it's a PPM, those are things that I would keep out of the stop loss contracts, because when you put it into premium, it's compounded with taxes and fees and margin. I mean, there's a lot of things that happen there. So you don't want to include that in the stop loss premium. Now, the attachment points are another thing. If you're going to give credit for it, that's a lot of times where you need to work hand in hand with those underwriters and say, this is what I'm putting together. I believe it's going to cause this much of a decrease. Please put my money where your mouth is. It's an area where you do the best you can to negotiate with the underwriter on. But Allison, you mentioned like reference-based pricing. There are some where it's a PPM and everything else is paid for as a claim. The underwriter needs to identify that and know that that's what they're placing in there. There are some where it's a claim, but then there's a percentage that's also placed on there for that claim to pay for the service. So you don't pay a PPM unless you're actually having a claim that's being processed under that reference-based price repricer. So it's an area where the underwriter just needs to know about that up front. It's why you should be building direct relationships with underwriters these days. You shouldn't just, go through a clearinghouse and ultimately have this thing that you don't have a relationship with. I suggest to make sure that you can pick up the phone, talk to the underwriter, know what they're seeing, help them identify if they're uncompetitive. Well, here's something you may have missed. A lot of people give underwriters 2 weeks. You just have 2 weeks to give a competitive proposal. It's a business that historically between 2 to 5% success rate, it's terrible. But you need to try to build those relationships. And quick plug for group captives. For me, it makes the stop loss more efficient. When you have an underwriter that you're building a relationship with, you're placing some more business in that group captive, you can identify if there's some fluff in the numbers. And if there is fluff, it's typically returned back to those employers. So it does make that more efficient, which is why I think a lot of these programs that are being built out for, different advisors and different solutions, group captives are really a significant way to make sure that you make it more efficient for those employers.
Fantastic. Courtney?
Well, shoot, I think Dale covered all the bases.
I feel bad to keep going first, Courtney.
Okay. Allison, did you have anything to throw in there?
Yeah, I have an example that might be helpful. So we talked about RBP and how if you're doing that at a point of service, that probably is covered as part, the fee is covered as part of a stop loss claim if it would hit your individual specific deductible. We just did a direct contract with a local provider for one of our clients, and he's a functional medicine doctor. And this is a client that has pretty low claims, except they get hit about every 12 to 15 months with a horrible metabolic syndrome claim. And we are trying desperately to control those. So we've contracted with this physician. He has created a few programs that help with obesity, diabetes, high blood pressure. And they're a fee-based program. They cost, X, Y, and Z. So we went to the underwriter and said, one, will you cover this under the specific deductible? And the answer was yes. And it's too soon for us to get any credit for that. But at some point we will ask once we see that it's working. So those are the kind of questions that those are the kind of things that you should be bringing to the attention of the underwriter. Right. It's not that there's necessarily, it may be covered as part of your ag, right? That's important, or it may not. Better to know that up front. And typically those are low dollars, but if the volume is high, it can be a significant number.
Okay. Christy Gupton has added a question here. I don't know that we've really evaluated the root cause of a lot of what happened last year. I'm not sure that taking a deeper dive into that is really necessary. But Christy's point is, I think if I'm interpreting it correctly, is that, seeing these, putting some solutions in place is a really great way for employers to start seeing that they can save money. Is there a point mid-year, whatever, where it should be reevaluated, where they could invest more in their administrative fees to save more on the claims down the line? So she says, when a health plan's innovative point solutions begin to show ROI, and the group sees their claims funding account grow and grow every month, some plan sponsors want to use part of those funds to reinvest in the plan design. Is there a helpful formula that helps determine if that's a good idea or not? I think it's a really good question. At what point, do we have to wait a year if we're seeing huge savings, or to be re-underwritten, or to reinvest? Is there a way to do that mid-year potentially? Dale, Courtney? Dale, you want to take it?
Yeah, I'll share a couple thoughts. Again, I've worked as a third-party administrator before, and I've had employers just ask us directly, hey, the money's sitting in the trust. I'm having a great year. I'd like to do something with that. And our suggestion was always to keep it in the account until the year is over. You never know what's going to materialize in the final month. All of a sudden, you have a monster claim. All of a sudden, the claims pile up. There's some type of lag with the hospital system, and now they're showing up. So sometimes you have sort of a false green flag that things are going really well, and you want to hold on to it as long as you can. Once you have that plan year, that stop loss year completely matured, and you still have some funding in there, great. I love it. Love reinvesting in it. Maybe before your open enrollment, going into your second year self-funded, you decide, hey, I think we're doing really well. The actuary says that claims in the IBNR are lower than they were expecting. So now we have a good indicator. You can start to reinvest in that, I would say, the beginning of year 2. In the middle of a year, I wouldn't feel comfortable moving funds in or out. And I think you could end up in a situation where you don't have enough money to pay for things that do materialize. And now you are sort of forced into a tough situation where you are paying more in that final month because you used it prior.
Got it. Courtney?
Yeah, I would just add, especially to Dale's point, especially if you're year 1 and maybe 2 or 3 of being self-insured. So those we've seen those mistakes made where they end up shorting themselves by taking a good concept, reinvesting in the plan based on positive experience through a certain point in time. But we're always same caution to keep funds where they should be until the end of the year plays out. But also, if you're on if the plan is on a run out contract, so if you've got a 1218 or 1224 contract, it's going to take a lot more time to develop out on that basis.
Allison?
I would agree with that. We typically use a 1218 contract, and so you wouldn't have a final accounting until 6 months after the plan year has closed. It's a very good window to make changes in the third plan year. So once you're 18 months in, then you get to the third plan year, and that's a good time to make changes. We also have this conversation often because we're asked. We talk about what it's going to cost you first, and then we look at what you've got. So you have a better idea of what you're actually, I know you're not spending it, but what you're actually spending. How much is it going to cost you based on the claims that we are aware of to decrease your deductible? How much is it going to cost you to make this service $0? And how much is it going to cost you to give a premium holiday or reduce employee or dependent contributions? How much is it going to cost you first? And then what do you have to cover that? Because you never know what's going to happen, and claims are taking longer and longer to file in a traditional environment. So you may be looking great until December 29th, and then you are not.
Yeah.
Let me add it quickly, just reference-based pricing as well. Sometimes those claims come in 18 months later. They just pop up, and you need to make sure it's covered under stop loss first and foremost, but B, just recognize that sometimes things just get delayed, and your TPA doesn't know about it. It just pops up. It's really, really difficult sometimes, and that's why you need 1218 contracts, paid contracts. You need to make sure you don't have any gaps in coverage.
Well, and that's a really good point. I know from being in the radiology business that a lot of radiologist claims, a lot of the professional fees don't go in intentionally until December, because it's much easier to collect from the plan than it is the patient. And they're hoping that the patient will have hit their deductible by that point in time. And so that's a known tactic that anesthesia and radiology use. So there is probably a heavy load, especially given kind of the escalating cost of professional fees for both of those things. So that's a great point. Okay, I want to get to really, this is kind of diving deep, but the contracting piece of this. The contracting piece of this, we started off being bolted on outside of the major health plan, not part of the major health plan, thus not subject to subrogation, to retro terminations, to a lot of the kind of dirty tactics that are being thrown in where, you can't, as a provider, we have huge costs associated with doing, offering that imaging exam, and then suddenly, oh, that may be covered by their automobile policy. Well, you know what? I'm not going to get paid by their automobile. Or it may be covered by their husband's Aetna plan. Well, you know what? I'm not in network with Aetna, and we didn't get an offer through Aetna. And so there are a lot of things that keep us from being able to be traditionally written into a plan, given, how we work. And, I can't undo those charges that I've already been subjected to. And if I'm written into, 10% of plans, I don't want everybody else to have to pay more who's bolting us on outside because, we're now being, subject to subrogation. So what thoughts do you all have from it? And this may not be an area of expertise. I feel like kind of not so much auto embedding solutions, but, having one agreement that has multiple agreements within it, so that we're not, so that point solutions are not as subject to some of these plan design issues. Dale, any thoughts or ideas on that? Does that make it harder, easier for underwriting? How does it impact underwriting?
I want to start with what you just finished with, which was one agreement for everybody. That's really difficult for a business owner to take liability over all of those solutions into one contract. That's risk on their parts, right? They may not necessarily have everything covered. And I would say the individuals that are doing that, are doing a great service to the market, making sure that everything is lined up in one agreement and wrapped tight with a bow. But I would also say, and this is, I'm no expert in subrogation, bring in your subrogation experts. I can think of FIA Group, MZQ. There's a lot of individuals, more compliancy, that I would bring in the discussion and just say, hey, I'd like for you to review this with me and just see, if I have some options here, how should this be covered? Don't feel like you have to go at this alone. If you're an advisor, make sure that you do have partners that you can reach out to and just ask, does this pass the smell test? Now, for you, Dr. Dickerson, you may not have those experts in hand. It's a tough road, and you just need to make sure that the third-party administrator is your partner and not necessarily somebody that could potentially throw you underneath the bus, right? So you want to make sure that you have a strong partnership there when you are offering the services to be outside of a PEPM. PEPM is clearly the safest, but I would definitely make sure that you do have strong partners through this.
And those are a couple of really good points, because I do think part of the problem was was trying to do everything in one agreement. I think that's one of the things that went wrong last year. And then also that, I think one of the things that helped us last year was really truly having a TPA as a partner and knowing them, having contacts there, meeting with them weekly. I think all of that, has been huge, and trying to get it right going forward as well. Courtney, your thoughts?
Definitely not an area of expertise, but I am curious so that I can kind of look at it through the stop loss lens. How does, in your world, it would be a charge, and in our world, in stop loss, it would be a claim. How do those, or do they differ between whether or not you're inside the plan or outside the plan?
Outside the plan, we're not part of the plan design. We have our own plan language. We stand as a preferred medical imaging network. And it's when we get written into the major plan that things that we never even thought about, problems arising, all the things I tried to get rid of, from my prior life as a radiologist, creep back in. And so that's been, a significant issue.
I will add that as a takeaway to give further consideration to.
Allison?
I'm going to add a couple of things. I think so much of this depends on the TPA and the advisor and the advisor needs to have a good relationship with the TPA, the point solution, and the employer. Because sometimes it's really easy to solve something if you will pick up the phone. And it's a 3-minute conversation and it's like, oh, yeah, right? Those things happen pretty regularly. The other thing I think is important is rules of the road. You shouldn't be subject to an issue for an auto claim because you shouldn't be involved in an emergent situation. An emergent situation should just be handled however it needs to be handled. You should be in place for every other type of solution, right? And the ASA should say that, right?
Yeah, that's another great point.
You know, you just shouldn't have to, that should be outside of your scope, right? If you've just been run over by a bus, you just have to go to be treated. It doesn't matter what it costs. Manage that later. Just, you know, get unflattened and everything else gets figured out later. And it's important that point solutions not be involved in those situations.
Yeah, and Rosalie Ferris made a good point. And, you know, that's what, you know, a lot of our navigation medical management companies are trying to establish that up front for us.
Right.
And that, you know, that's greatly appreciated and very helpful. So thank you for that. And then they'll go to bat for us too. That, there's also been that, you know, and help us get, if the patient has, you know, potential, you know, maybe coverage by another insurance, they help us get that, you know, form completed by the patient. And so all of those things are greatly appreciated. That's, again, where having good partnerships, having good I won't use partnership because that's a legal term. I'll use good collaboration with these other solutions that are in the market are, you know, really makes important. And I want to go back to that. I think next, for the next meeting, we want to talk about the relationship between TPAs and point solutions. I think that's going to be a great topic of conversations. If you have other ideas for our, you know, webinar meetings that we're doing, we do need to do an in-person this year for the Houston group. But I do think, you know, we're getting great attendance on the webinars and great interest, and I'm learning a lot. I don't know about y'all, but I'm learning a lot. And so I think if you'll drop any in the chat, drop any ideas for future meetings in place and potential panelists as well. I think I want to thank Dale and Allison and Courtney for being an amazing panel today, bringing a lot of value to the conversation, a lot of perspectives to the conversation. And thank everybody for being here. This was really interesting to me and helpful for me. And I love building these relationships across the industry. So thanks, everybody.
Thank you for having us.
Thank you, everybody.
Roll this back so there's contact info.
Thanks, Dr. D.
Thanks, Allison. See you soon. Will you be at FMMA?